Good evening. It is so nice to have so many parents and families join us this evening. To officially kick us off, we are so grateful to have our Chancellor, Chancellor Jean Block, provide us with some introductory remarks. Welcome, Chancellor Block.
Thank you, Suzanne, and welcome to parents and families. It's been almost exactly a year ago that instruction at UCLA went remote. It seems like decades ago now, but it was a year, a long time still. And it's been a challenging 12 months. I'm grateful to you and your students for your resilience. Obviously been a challenging time for families. But I truly believe we're starting to see the light at the end of a very long tunnel. Our adherence to public health guidelines and mass COVID-19 vaccinations are helping LA and other regions show signs of recovery. The FDA emergency use authorization of Johnson & Johnson new vaccine will only contribute to this very exciting result that we just heard about recently. Mass vaccinations will also provide the quickest path to bringing Bruins back to the UCLA campus for in-person instruction. And so while we previously announced that the instruction will be remote through the summer, we are planning and hoping for a return to campus this fall. However, the decision is not ours alone. LA County guidelines dictate what we can and can't do, and we're working closely with the county and we're advocating for a safe reopening. As you'll hear today, UCLA plans to offer vaccines to every eligible student, staff, and faculty member at no cost. We view this as part of our public mission and our commitment to community. But if your student is outside of LA or qualifies to receive a vaccine elsewhere first, I encourage them to get it. UCLA must abide by a vaccine distribution schedule set by our county and state, so we may not be the quickest option for your student. I know there are some in the community who have concerns about the safety and efficacy of the COVID-19 vaccines. All of the vaccines are approved by the FDA, have undergone rigorous clinical trials that have included people of all racial and ethnic backgrounds. I join our experts at UCLA Health in my belief that the benefits of receiving vaccines to you, your family, and the community far outweigh any risks. As I've said before and say again, I remain eternally grateful and proud for our students, all they've done to rise and meet the challenges of this pandemic. I know it has been stressful. I know it has been challenging. I know remote education is not something any of us expected to use for such a long time. So I truly am impressed by their accomplishments. I hope today's town hall is engaging and informative. Please stay safe. And I truly hope to see you in person very soon. Thank you.
Thank you, Chancellor Block. And as mentioned, so tonight's focus is on COVID-19 vaccine. And while I'm sure there's many different kinds of questions you have, tonight we've assembled a group of key staff members who are part of this town hall, who have worked actually tirelessly on all things COVID over the last year, including in terms of the vaccines and the rollout of the vaccine and understanding the vaccines. So we thank all of you who have submitted questions ahead of time, and we've done some pre-work to be able to take those questions, and many of them will be incorporated into the presentations that are provided by a number of our panelists. And then we will go through specific questions and answers that perhaps were not answered through the presentations, and be able to try to get to as many questions as possible. So without further ado, I'd like to introduce our panelists to you. So our first person is John Ballard. John is our co-executive director of the Arthur Ashe Student Health and Wellness Center. Next, we have Dr. Edith Flores. She is one of our primary care physicians at the Ashe Center. Then we have William Dunn, our Administrative Director for Emergency Preparedness, Safety, and Security Services at UCLA Health. And finally, we welcome Dr. Annabelle de St. Maurice, who is our Co-Chief Infection Prevention Officer for UCLA Health. So we will first start with an overview of the situation in LA County and the campus COVID-19 protocols for testing and contact tracing with John. Thank you, John.
Thank you, Suzanne. And thank you all for joining us tonight. It's a real pleasure to be here with you tonight. I'm going to spend just a few minutes, as Dr. Seplow said, giving you a very quick overview of what's going on in Los Angeles and the county. I know that the interest is really in vaccines, but what's going on campus is something that we want to make sure that you're well aware of. First slide, please. So what we're looking at here, I just have a few slides that should give you some information. Right here, we're talking about Los Angeles County. And I know that you're undoubtedly aware of the surge that happened across the country, really in early December through early January. And that's what you're seeing here in both of these graphs. This is Los Angeles County through the beginning of March with 1.2 million cases reported. And you can see that the decrease after the surge happened just as quickly as the increase. Unfortunately, there were a lot of deaths during that time, but now things have stabilized significantly. And the second chart there in blue shows the positivity rate, which really represents the percentage of those who test positive for COVID-19. You can see now at one point, I know it's a little hard to read, we're over 20% in Los Angeles County of people who tested positive. Now, thankfully, that 7-day average is about 3.1%. Next slide, please. I want to share this with you because it shows how UCLA compares to the state and the county. County in red, state in gold, and then UCLA in blue. And this again looks at the positivity rate, the percent of those who test positive. And even during this surge, which is represented there in the middle, UCLA has been very fortunate to have a very low positivity rate, even though we're doing a lot of testing, which I'll talk about in just a minute. So at our peak of that surge, we were just at 2% of positivity rate. For the vast majority of the pandemic, we have been below 1% positivity rate. And we'll talk a little bit about why that is. Next slide, please. These are the on-campus numbers of cases of faculty, staff, and students who have tested positive for COVID since testing began. 23, almost 2,400 is not a small number, and it represents a fair amount of illness and suffering for those who have had bad cases of it. But when you look at us compared to other universities around the country that maybe opened up a little bit more or a little bit sooner, our prevalence on campus has been very low throughout. Next slide, please. And the final one I want to show you is really the daily cases. The students are in gold, staff and faculty are in blue, and this chart goes from early October to current. And it mirrors the county in terms of that surge. On one day, we had over 130 positive test results. We were testing people twice per week, running 20,000 tests a week for faculty, staff, and students on campus. Now, thankfully, and what I really want to show is these last few days and weeks, we had 2 positive cases yesterday and 1 the day before that. So we are back to being in much better shape. Next slide, please. This has a lot to do with why I think our positivity rate has remained low. The campus invested early on in a really robust process, invested in people and processes and technology, so that everybody who's coming to campus or living, learning, or working on campus does a daily symptom monitoring survey. Should they fail that survey, have you been around people who have been positive? Do you have any symptoms? They are immediately contacted to test. They're placed in quarantine or isolation. If they test positive, we immediately begin contact tracing and then start over with their close contacts, bring them in for testing. So this really robust process that's able to happen very quickly, when built upon the foundation of those non-pharmaceutical interventions of mask wearing and social distancing and all the things you're so familiar with, those things in combination have really helped us to keep the pandemic mostly at bay on campus. Next slide, please. The other piece is a very robust testing process that we have here on campus. Since we began testing, and mostly since October, we've done more than 225,000 COVID tests of UCLA faculty, staff, and students. They have the opportunity to go to multiple locations on campus. We have a mobile testing clinic that goes to apartment buildings where we know students, and especially graduate students, live, so they don't have to come to campus to test. And as I said, currently, we're testing most people every week. Next slide, please. Before just going on to this, I would say one last thing about our surveillance testing program. The benefit of having that kind of a robust testing program is that it's able to pull out people who don't know that they're positive, right? More than 40% of transmission happens by people who have no symptoms. So that's been a really important part for us to be able to quickly identify those people who are positive but don't know they're positive. The other important investment the campus made early on is in contact tracing. And that's happening here on campus as opposed to the county, which is responsible for a lot more of the contact tracing. We, at the peak of the surge, had 15 full-time equivalents working on our team to do contact tracing. They were able to get to people within 24 hours of a positive test result. That was key in helping to slow the spread of the disease during its worst time. The last thing I'd say is the campus also put a lot of resources into making space available on campus for those who couldn't isolate at home for whatever reason. We had a lot of people, students, faculty, and staff, take advantage of that. They came here, were well cared for during the time that they were ill or in quarantine. And that has worked really well to help slow the spread as well. Next slide, please. This is the last thing I want to say. You know, we're all waiting for herd immunity, that point where we reach a certain percentage of people who are vaccinated, such that if you drop a COVID positive person into that population, the disease won't spread or won't spread much. But while we wait for that, it's so important for us to continue to do those kinds of things that we're all getting pretty tired of doing, right? Masking, distancing, and disinfecting. We want to encourage people to continue to test as often as you can test wherever you're able to test. And finally, to not let our guard down now. It's so tempting with that proverbial light at the end of the tunnel that we're all talking about. But if we do all of these things, we feel really confident that we'll be able to continue and start to open up and be really open and vibrant in the fall and keep the positivity rate and the prevalence of this disease low on campus. Thank you so much. I appreciate your time.
Thank you, John. And next we have Dr. Flores from the ASH Center to share with us a little bit about the vaccines themselves. Thank you.
Hi, my name is Dr. Flores and I work at ASH Student Health, and I just wanted to talk about the 3 vaccines that are currently available in the United States. Next slide, please. So right now we have 3 vaccines. 2 of them are what's called messenger RNA vaccines, which include Pfizer and Moderna. And one of them is the newer Johnson & Johnson vaccine, which is a viral vector vaccine. How's that for some alliteration? The messenger RNA vaccines both require 2 doses, and Pfizer will vaccinate anyone ages 16 and up, Moderna 18 and up, and Johnson & Johnson 18 and up. Next slide, please. So I just want to say that none of these vaccines are FDA approved. They have received emergency use authorization, which is only granted during an emergency. And these vaccines have to, their known and potential benefits have to outweigh the known and potential risks. And finally, these vaccine candidates have to reduce infection by 50%. And all of these vaccines have outpaced that rate. Next slide, please. So I just wanted to show the vaccine life cycle here, basically to show how a vaccine gets approved. The orange sort of arrow on the left shows the preclinical studies, the basic research that happens before the green part, which is where your clinical studies occur on people. The phases are meant to deal with, or rather are meant to show safety, effectiveness, and dosaging. And the reason I wanted to show this slide is because even though these vaccines are not FDA approved, they are held to the same exact standards that any other vaccine that's received FDA approval. Next slide. So this is a very simplified slide on how the messenger RNA vaccines work. But before that, I just want to say that in general, vaccines work by exposing the body to either an entire vaccine, a live vaccine, a piece of the vaccine. But these vaccines work basically by giving the body a recipe for a part of the vaccine that the body then fabricates. So on the left of the slide, you see the spike protein. It's what is used by the virus to get into cells. And so the messenger RNA viruses work by giving the body the recipe or the blueprint to make a spike protein. This is injected into the arm. The muscles will, the cells will then make messenger RNA. Will make the spike protein. And then the body will recognize the spike protein as something foreign and build antibodies so that if you're exposed to it in the future, you will be ready to fight the infection right away. Next slide, please. Pfizer was the first vaccine that came out, and within a day or two, there were reports of severe allergic reactions. And during the trials, there were allergic reactions as well. They are rare in both the Pfizer and Moderna. And the Johnson & Johnson, the trials didn't have any severe allergic reactions, but now that it's being used, they are being seen. And so at this point, it's too soon to tell how common that is. Next slide, please. So with regards to allergies, there are some recommendations as to who should get it, who can't get it. And I call this the yes, no, maybe so slide. If you have an allergy to oral medications, sulfa, penicillin, if you have environmental allergies to animals, venom, latex, eggs, or a family history of allergies, you can get these vaccines. If you have an allergic reaction to the messenger RNA vaccine, that's Moderna or Pfizer, that's a hard no. You could not get the second vaccine. The maybe so would be someone who has an allergic reaction to any other vaccine or injectable therapy, in which case you look at the risk benefit, and if they're at increased risk for high risk, if they're at high risk for bad disease, then they would be vaccinated under controlled conditions. Next slide, please. So the viral vector vaccines work in the following way. Basically, instead of the recipe as the messenger RNA vaccine, instead of injecting the recipe, what you inject is a cookbook with only one recipe in it. So the cookbook would be the adenovirus, which is a virus that causes common cold. It's modified and basically stripped of its ability to cause disease, but within it is sliced the blueprint or the recipe for the spike protein. On the second part of the slide, it just shows that it's injected to the body. The body will then make the spike protein, and the same process will occur where you get an antibody response. Next slide, please. So, of course, there's going to be comparisons with the new viruses that are out. And the comparisons that are being made right now are really not fair, because the Johnson & Johnson vaccine, I think people look at it like, oh, this is not as good, I don't want this one. But it's important to understand that the trials for these vaccines were set up to measure different things. So the messenger RNA vaccines were to prevent symptomatic disease, where the Johnson & Johnson vaccine was whether this vaccine can prevent moderate to severe disease. Also, the timing of the trials was different. So again, messenger RNA vaccines were done earlier during the pandemic, whereas the Johnson & Johnson is done in the setting of these emergent variants. So would the messenger RNA perform as well if their testing had been done now? The only way to tell that is by doing a head-to-head comparison, which nobody has time for, and I'm sure won't be done. Anyway, next slide, please. So basically, here are the numbers. With the Johnson & Johnson vaccine, it will reduce your risk of developing severe disease, which is defined by respiratory failure, ICU admissions, shock, death, in short, badness, by 85%. That's really good. That's really good. And the other thing is that in the United States, it reduces the risk of developing moderate to severe disease by 72%. That's in the United States. It's lower in South Africa and Brazil, and globally it's a 66%. And these symptoms would be either one respiratory symptom or blood clot formation, or two of the flu-like symptoms listed there, fever, chills, sore throat, etc. Messenger RNA vaccines, of course, everybody knows 94 to 95% reduced risk of symptomatic disease. Next slide, please. So there are advantages of the Johnson & Johnson vaccine. One is that it's a single dose, so less time commitment, it's more convenient, and it eliminates the logistics of ensuring that people get their second dose. And up until recently, there was debate as to whether they should hold those second doses for the people who had received the first or give them to everybody. So that kind of gets rid of that. And the other thing is that it can be stored in regular refrigeration for 3 months, which means that it can be stored in smaller clinical offices, and it's less expensive, not only because it's one dose, but one dose of the Johnson & Johnson vaccine is cheaper than one dose of Moderna or Pfizer. Next slide, please. Okay, side effects of the available COVID-19 vaccines. These are all three of them, what's called reactogenic, meaning that you can get some side effects from it. The most common by far is pain at the site of the injection. You can also get flu-like symptoms like fever, headache, muscle aches, joint aches, etc. It's more common with the messenger RNA vaccines, particularly after the second dose, and also amongst younger people. And the side effects are not a sign that anything bad is happening. It's a sign that the immune response is happening. Next slide, please. So what's the vaccine's role in reducing COVID-19? Well, one, we have 3 very effective vaccines that are not available to us. Yay for us, but it's not enough. If the goal is to reduce the spread of this disease, to reduce the infections and the death that it's caused, people have to be vaccinated. If too few people are vaccinated, it doesn't matter how good the vaccine is. And it's estimated that, or guesstimated that to reach herd immunity, 70 to 80% would have to be vaccinated. The other things is that we're sort of in a race with these mutations that can lead to variants that can potentially sidestep our vaccines, which would really be a huge step back. So as a result, masks, social distancing, hand washing, crowd avoidance, all that stuff that we've come to love over the past year are still important during this time. Next slide, please. So many people have concerns about getting vaccinated. So for example, with pregnancy, COVID increases the risk of pregnancy complications and also developing severe disease. So pregnant women should be vaccinated. If you've had COVID-19 and you're not in isolation, you should also be vaccinated. It's not clear how long your natural immunity will last. Finally, especially amongst young, healthy people, the survival rate is high, and I'm at low risk for severe disease, so why should I get it? And part of that is because while that might be true, you can still spread the disease to other people who are at high risk for severe disease. Some people want to wait because this is new to see how others fare before deciding. And as I mentioned before, vaccinating people as quickly as possible is going to be an important way to get COVID behind us. And finally, the vaccine was developed too quickly. And to that, I would say yes and no. As I mentioned before, it's held to the same standard as any other vaccine. And the second thing is, if you throw a ton of money and all hands on deck at something, it's going to happen fast. And that's exactly what happened here. Next slide, please. So vaccinated persons should continue to follow all current guidance to protect themselves and others. We don't know how long the vaccine-mediated immunity will last. We don't know if a person is vaccinated, are they still able, and they're exposed to COVID. It's unlikely that they'll get sick, but could they still transmit the disease? And it's also, we don't know how effective the vaccine is against asymptomatic spread. I think these answers will come shortly, but right now we don't know. Next slide, please. And okay, no, that was it. Thank you.
Thank you, Dr. Flores. Next, we have Bill Dunn, who's going to share with us a bit about the vaccination overview. Thank you, Bill.
Good evening, everyone. Just wanted to spend a little bit of time talking about our vaccination program and trying to provide as many updates as we can Unfortunately, there have been significant changes since the beginning of the rollout in mid-December in the state of California. So we'll try and address some of those and to the best of our knowledge where we stand right now. So the first question is, who's eligible to get vaccinated in California currently? So back in December 16th, we actually started in what's known as phase 1. And we worked diligently to offer vaccinations to our healthcare workers, and then eventually into our long-term care residents, which include skilled nursing facilities, assisted living facilities, et cetera. So we've continued to work through progress in vaccinating those individuals. Last month, in late January, the state opened up the opportunity for individuals 65 and older to be vaccinated. So we've been, again, making progress in that particular age group and sector that are extremely vulnerable to hospitalization and death related to the COVID virus. And this past week on Monday, the state opened up risk-based occupational sectors to include agricultural and food service workers, education and childcare, and emergency services. So the area that's most concerned or most applicable is certainly the education and childcare area that again opened up this Monday. So related to that, next slide. We also believe that on March 15th, the next tier will open, which will include those between the ages of 16 and 64 who have the highest risk of disease based on underlying pre-existing medical conditions. So those are listed there for you so that you can walk through those. But again, it will allow those individuals that have these current conditions or have had them in the past to be eligible to be vaccinated. Again, these through research, we know that these particular individuals have had significant risk of hospitalization and fatality associated with COVID-19. If you look at the bottom of this slide, there's also the opportunity for those that as the result of a developmental or other severe high-risk disability will also be allowed to be vaccinated as part of this particular tier. And again, we anticipate that this will open on March 15th. Next slide. So just to give you a context of where we are in our program at UCLA, so our initial phase, or the 1A group, the healthcare worker group, we've invited about 99% of the individuals that fall into that category. We initially requested over 37,000 doses to ensure that we had enough vaccine to allocate that for our faculty, staff, and trainees at the health system, School of Medicine, School of Dentistry, School of Nursing, ASH Student Health, our counseling and psychological services, UCLA first responders that respond into the hospitals and health system, and also UCLA campus employees who directly support patient care. So again, we've offered that, and I'll show you some data on that very soon. Next slide. The second group, as I mentioned, we utilized the opportunity to offer vaccinations to UCLA faculty and staff, and also students over the age of 65 years of age. So we identified a little over 5,300 individuals, and we did some initial risk stratification based on age and then social vulnerability index. So again, trying to offer vaccination when we had limited supply to those individuals that had the most vulnerability. So again, we've invited that entire group at this point. Next slide. Our next steps, again, as I mentioned, started this week on Monday, and we did get confirmation from the state and county public health departments that we could include all of higher education faculty and staff, and actually students that are employed by the university in our Tier 1B1 education sector. So again, we've started that process. And as I mentioned, again, the next tier will open up in a couple weeks related to our individuals that have underlying medical conditions between the age of 16 and 64. And this would again include faculty, staff, and students who meet this criteria. Next slide. So where are we in that rollout? So as I mentioned, we have completed our employees, faculty, staff, and students 65 and over. Our next groups, again, because we don't have enough dosages allocated to offer vaccination to every faculty, staff, and student at this point, we built some additional risk stratified tiers. So our first groups are high contact, high location variability employees. So residential life, housing, food service staff, ASUCLA, again, faculty and staff and students that are involved. We've completed a majority of these invites. We sent out many on Friday night and began that vaccination on process on Monday morning. So that was about 2,000 personnel on campus. Our next group is our custodial grounds, skilled trades, mail and document services, parking, transportation, environmental health and safety. Again, those individuals that work on campus in person that are moving through many areas, may respond in emergencies, et cetera. So today we've been working through developing medical records for those personnel. And the next group is our pre-K through 12 teachers and staff and childcare teams, about 160 personnel, again, working through medical record development today. And we're hoping to offer those personnel invites in coming days or weeks. Our next groups will be research faculty and staff, and actually students who are already on approved ROPs. So research ramp up components, faculty teaching in-person courses, faculty and staff working on site, or in support of remote instruction. So that's a little over 4,000 personnel. And then again, we'll move diligently into other on-site employees, and then start looking to offer off-site educational essential employees additional opportunities. Next slide. So our current status, we've invited over 40,000 faculty, staff, and students. We have, again, yes, offered over 40,000 faculty, staff, and students. Over 27,000 have received their first dose, and over 23,000 have received both doses at this point. Next slide. So you can see the breakdown there, again, between our faculty, staff, and students. And again, where in different sectors of our organization, we have different compliance rates or offering rates. Next slide. So where does this all leave us right now? Well, there have been some changes, as I mentioned. Initially, all of the allocations and strategies were being controlled by the State Department of Public Health and county public health systems. But the governor in the past about 45 days has made a decision to pivot to utilizing Blue Shield as a third-party administrator. And we've been in contract negotiations. The UC system did sign a contract with Blue Shield to continue to be a vaccination provider. However, along with this, there is significant focus on mass vaccination sites or mega sites that you've probably heard about in the news. And utilization of a single sign-up system called MyTurn, which is a web-based tool for individuals to be able to sign up and then be notified when they're eligible for vaccination, and then for them to be able to sign up as doses are available. The challenge with this particular methodology is that it's really first come, first serve. And UCLA and UCLA Health truly believe in equity, and that we really want to try and offer vaccinations to those that are at the greatest risk. And unfortunately, this particular system has not supported that, and we're very unsure about how that's going to support this in the future. With this new contract, there is also a potential inability for us to be able to prioritize UCLA personnel, students, or patients. And if we need to move to this MyTurn system, that we would only be allowed to open dose administration appointments up to the general public, that we wouldn't really be able to close appointments specifically to our at-risk patients or our most at-risk faculty, staff, or students. And it's also required us to zero doses out every week. So when we've had weather challenges or there's been delays in dosages, that's required a lot of our sister institutions and organizations to cancel appointments. So again, this makes us a little bit anxious in the process of continuing rolling out vaccination strategies. Next slide. So again, as I mentioned, we did sign a modified contract last week. We're going to continue to offer appointments based on available doses and risk stratification. However, we're also referring all faculty, staff, and students to register today on My Turn. And if there is the opportunity for individuals to get registered and get appointments, we certainly encourage them, whether it's through large mass vaccination sites or other community locations or through their own medical provider, that if they get an opportunity to take the first available vaccination opportunity. If we do see continued limited future doses, and again, we're not permitted to direct schedule, we will again continue to refer people to My Turn in an effort to get vaccinated. Next slide. So if we do have the opportunities again to move forward, we do have 6 locations currently in UCLA Health. We have 2 large sites at our major medical center campuses in Westwood and Santa Monica. We also have 4 clinic hubs that again are processing between 500 and 1,000 vaccination dosages per day at each location. 1 in Torrance, 1 in Santa Clarita, 1 in Calabasas, and 1 in Thousand Oaks. And if we start seeing significantly larger vaccine allocations, we have opportunities to move vaccine availability into all of our primary care clinics. There's over 100 of them in Southern California in the 5-county region from San Luis Obispo, Santa Barbara, Ventura, Los Angeles County, and Orange County. So again, we're hoping that we will start seeing some larger allocations soon. Next slide. Thank you very much.
Thank you, Bill. And so now we're going to try to get through as many questions as possible, those that were submitted prior, as well as those that are coming in through the Q&A. So the first set of questions, and I'm going to lump a couple together, but for Dr. Day St. Maurice, if you could share just, we've gotten some questions around, does the vaccine prevent the person from getting COVID-19, from spreading COVID-19? And if you could also maybe just reiterate what Dr. Flores said as it relates to what should I be thinking about if I have allergies?
Sure. These are all common questions. So as far as preventing you from getting illness, all of the vaccines are effective against you becoming symptomatic and having COVID, as well as developing severe illness or being hospitalized from COVID-19. As far as transmitting to others, those data are still pending. We do know that preliminary data suggests that some of the vaccines are effective at reducing you from having COVID-19, even if you are asymptomatic. But further studies still need to be conducted. And in order to really know if it prevents you from transmitting the virus, you have to do contact tracing on people who've been immunized and who've had COVID-19, just to make sure that it reduces the spread. But as the data have demonstrated, as vaccines have rolled out in LA County and in skilled nursing facilities in particular, we've seen rapid decreases in the rates of COVID-19. So this does suggest that as people become immunized, it really does reduce the spread. But again, we still need more data. As far as allergies are concerned, certainly if you have any specific concerns, we would recommend that you discuss these with your allergist or immunologist or even your primary care doctor. However, For any severe allergy to an injectable or vaccine, that's really the only contraindication to any of these vaccines. And that means anaphylaxis to any of the any prior vaccines or ingredients in these vaccines or injectables. This should be very, very rare. Other allergies, such as anaphylaxis to other things like food, etc., might just require you to wait for 30 minutes, but we would recommend that you follow up with your primary care doctor before receiving the vaccine if you have any specific concerns. I'll also put in the chat a great CDC website that has some of this information that might be helpful to those of you who might have specific questions about allergies.
Thank you so much. So a very popular question is, are vaccines going to be required? And I'm not sure who wants to give this a shot, but John is smiling. So I'm going to call on John, and you could start us out here, and I might be able to pitch in and help out as well.
Thank you. Yeah, I wish I had the complete answer to this question. What I can tell you is that there's quite a bit of support on campus and across the UC system for requiring the vaccine of all students who, whether they live on campus or not. The reason why that decision hasn't been made yet is that the vaccines are still under emergency use authorization, and they want to wait for full FDA approval before making that decision. We are hopeful about it. You know, there's already a vaccine immunization requirement for incoming students. And this would be hopefully rolled into that requirement, although it would hopefully apply to all. We're hoping that a decision will be made in March about that, and it will be communicated out broadly as soon as that decision is made.
Bill, did you want to add to that? Or I didn't know if you were coming off camera just to have all the panelists off camera. So.
As I think John mentioned, because the vaccines are still under emergency use authorization, from a broader societal engagement, we really want to make sure that people have the option at this point to accept the vaccine, looking at their own risks and benefits related to that. Obviously, we hope that everyone will be vaccinated, but I think in the short term, that's really been the direction.
Great. And I appreciate that, Bill. And I will also say that there's questions as it relates to housing and mandatory and housing, and it's all tied in terms of, you know, the campus decision that is in part in terms of the vaccines right now being under the emergency authorization. But that is being discussed not only on our own campus, but throughout the UC system. So more to come on that. And as soon as we do have a decision, we will share that with everyone. The other popular question I would say, and maybe John, you could speak a little bit more to this. Can you share where exactly are students in terms of getting the vaccine, and will students be able to get the vaccine through UCLA? So maybe a little bit more delving into how does my student potentially get the vaccine, and can they get it at UCLA?
Sure. So in California, the priority system that the state is dictating puts the general population a little bit down the road, right? So we're not there yet. They're focusing on the educational sector. If your student is an employee of the university, even if they're a student, they do fall under that, and they're eligible now. If they have an underlying health condition, as Bill said, starting on March 14th, they will be eligible to be vaccinated, and there's some information on the student health website about that. In terms of the broader sort of students without health conditions, without employment, we don't know exactly when that's going to happen. We're very hopeful that the floodgates are going to open soon for the vaccine, and that within the next couple of months, the broader population will be eligible to be vaccinated. As Bill said, we don't know whether that means they'll be able to do it on UCLA's campus or not. We are ready to, the Student Health Center is ready to participate in the vaccination of students if that becomes possible and when that becomes possible. We also don't know if there is, I saw this as a question, so let me just tag it on now. We don't know that if it is required, whether it will be required to be done prior to arrival on campus or not. I know a lot of people are concerned about that, but once the decision is made and communicated, all of those kind of details will be included in it.
Great, thank you, John. Anybody else wanted to add on to the mandatory before I move forward? Okay, well, John, since you're still front and center, one question that was asked prior to the webinar was just in terms of how do we know what students are getting, those that are getting tested, how we know that they're getting tested, how will we track as it relates to vaccinations, particularly if they are required. Can you talk a little bit about how we do that?
Sure, let me break it up into those two areas. So with testing, we have some really great technology that has been developed very quickly as a result of the pandemic that allows us to track testing. We know how many people test, we know who tests positive, and all of that contributes to our contact tracing efforts. It's all done securely in a HIPAA secure way, and that information is maintained securely. When it comes to vaccination, right, we've been doing this for a while because of the immunization requirement. And for students, at least, we will use the same system that we use to collect their immunization records. It'll be an ability to load those into our electronic medical record. And we'll be sending out a lot of information about that. And that will allow us to collect and know exactly who's vaccinated, who still needs to be vaccinated, and that'll contribute to a lot of the decision making on campus as well. But we know how to do this. We've been doing this for a while, and we're prepared to do it.
Thank you, John. There have been a number of questions as it relates to just kind of the return to fall and the timing of that and the timing of understanding housing options. What we can share is that there are a number of campus work groups that are made up of faculty, staff, senior leaders, students, really working through kind of what can we do. And I will say from the get-go that it's really important to know that for us at UCLA, we are working hand in hand with LA County Department of Public Health, and that we need to abide by the guidelines of LA County. So while you may see things that are happening across the country and even across the state that are different potentially from what's happening at UCLA, that's in part due because we are needing to be, in step with LA County, who is providing the guidelines of what we can do. So when we think about housing, for example, LA County will provide us the guidelines about what the density within our housing can be. And so that'll take into account how we then can determine how many students will be able to live on campus. Our goal is always to give as much information as we can when a decision is made. Part of the balance to this is not making a decision too soon, given that fall quarter is October. In truth, I mean, we begin to ramp up certainly in September, but a lot of times it's that last week of September that we start classes. So we want to make decisions that can help you and your students, your plan as best as possible, while also giving us the greatest amount of time to be able to make the best decisions for the fall. I also did see in there a question about summer and summer housing. And at this point in time, there is no shift in being able to open up more housing for the summer. So our focus is trying to see what we can do for the fall. So I did want to try to address and share a little bit about that, but I'm wondering if maybe Bill or John can just talk a little bit more about our work with LA County and how that plays a part in terms of the campus decisions.
Sure. So as Seppi mentioned, it is really important to recognize that Los Angeles County has had some of the most challenging transmission rates, fatality rates, et cetera, in the state. About 1/3 of all cases have occurred here in the county. And again, based on population size and density, we would expect that to be the case. But as transmission rates have decreased drastically over about the last 6 weeks, we are starting to see the opportunity to get closer to reopening tiers that we haven't seen before. So if we had a crystal ball and based on some of the data that we're seeing, we're hoping that we will move from the most restrictive reopening tier, purple, next week potentially into the red tier if things continue to fall as far as new case rates. We're already in that opportunity for related to transmission rate, so positivity testing rate. So county has done a good job in bringing that down, but we still have more opportunity based on new case rates. If that occurs, then the county will allow more reopening. And there have been, I think, very strong positive relationships with the County Department of Public Health since the beginning of the pandemic between UCLA Health, and the County Health Department to really try and advocate for our students and their education and their well-being, but also, again, make sure that we balance that with the broader risks, health risks for the students and faculty and staff and the broader community. So I think it's really important to mention that, again, we can only go as quickly as the surrounding community will allow us to do that.
Thank you, Bill. And yeah, and I'm just trying to look at the chat as well. And so it is just important. Different campuses have been able to do different, take different actions and have greater numbers of students live on campus or be in person, given the county and what the restrictions have been. Perhaps for one of our doctors on the call, I will ask, there was a question, why isn't type 1 diabetes included in the list of healthcare conditions in phase 3? Give any insight about that, either,
Yeah, I think that we didn't come up, unfortunately, with these criteria. It's based off of the risk delineated by CDC and based off of data and evidence for health conditions that put individuals at increased risk. We do realize that there are some conditions that may put individuals at increased risk that aren't listed on there, but again, it's perceived as those who are at really the greatest risk of having COVID-19. And Bill, maybe you can speak to some other tiers and phases that include some of these other conditions and how we're prioritizing that.
So if we went back a number of months ago, there was not only federal guidance based on data at the time, state guidance, and then also some county guidance. And the tiering system, unfortunately, has changed pretty dramatically since that process. Not only were there more tiers regarding underlying pre-existing medical conditions and age groups, but also different occupational risk assessments as well. And so a lot of that has changed over time. And again, we don't know how successful that will be or not. But as Dr. D. St. Maurice mentioned, the pre-existing medical conditions are really those that have been linked from hospitalization and fatalities for the most severe disease processes related to COVID-19. So while it isn't as inclusive as I think many of us may like, it really does try and identify some of those most at-risk populations.
thank you to both of you. There was also a question in terms of just if I'm living out of state or out of the country, is it encouraged that I get my vaccine if I can now where I'm living, or wait till I'm potentially back at UCLA? I know the answer, but I'll let someone else answer. John, you want to?
Sure, I'm happy to, sorry. Yes, we encourage you to get the vaccine at the first opportunity that you have to get it. If vaccines are required of students when they arrive to campus, I'm told that international vaccines will be accepted as part of that requirement. But do not wait for the opening of UCLA vaccinations. Get the vaccine as soon as you can. We strongly encourage you to do that.
Great, thank you. There are also some questions, John, just coming through as it relates to I'm close to campus. And I know you talked a little bit about this in terms of students getting the vaccine. And there's a lot of resources that are put in the chat in terms of about getting the vaccine. But if a student has a question as it relates to vaccines, but also testing, if they're close to campus and they haven't been getting tested, but they want to get tested, can students just, connect with ASH and or come to campus for testing and then also vaccines?
Absolutely. We want those students to come to campus to test. We're testing about 4,000 students per week and about 6,000 faculty and staff. So we have the capacity to test these students. If they want to come to campus, they can go to the ASH student health website, studenthealth@ucla.edu. There is information there on testing sites and locations, links to sign up for it. So we definitely encourage it. It's easy, it's quick. It'll take you about 10 minutes to test. And we'd love to see you at those test centers.
Thank you so much. So I know that there are lots of questions well beyond just the COVID-19 vaccine, which was what we were coordinating the town hall for. And we want to recognize and appreciate that there are many unanswered questions. And I can tell you that there are many of us that are working each day to try to get answers to those questions and be able to communicate that to you all and to our students in a way that continues to bring hope about what the future is and about coming back to campus. And there is the desire for us to be, mostly in person in the fall, with also knowing that not everybody will be able to be in person. And I've seen in some of the questions as it relates to just what if I'm not able to come back in person, and will I still have opportunities? So that is exactly what we are trying to figure out and balance in terms of both. We know that many, many, many folks, our students, undergraduate students, new incoming, those that are first year students now and that are, never been to campus yet, to our graduating students in terms of what does it look like for the remainder of this year and what will it look like for the fall. What I can say is that we will work with parent and family programs to provide as many answers to questions that we weren't able to get to, and also I will make myself available too with parent and family programs for continued dialogue so that you feel like there's access to us and that we're being responsive, because we do want to provide you with the best information that we can, so that you can continue to make decisions and also maintain that optimism with us about where we're moving forward. So I want to thank everyone for joining us. I apologize for those questions we weren't able to get to, but please know we're committed to being able to answer your questions and continue and remain in dialogue with you. We know that you are an important part of our Bruin community and that we care about you and your students and want to do the very best we can as we continue to move through this global pandemic. So I want to thank all the panelists for your time and for your insights and for your work on the campus, and thank our parent and family programs for putting this program on, and for all of you for joining us. Thank you so much.